Hello, I'm Dr. John Kruse, and welcome to today's question and answer session where I will try to answer questions about the videos released this past week, about ADHD in general, and about broader mental health topics. And one of the videos touches on broader mental health topics. So I'll review those two videos. Hello, I hope I'm back again. Maybe. Okay, so we're back. So I'll re-summarize really quickly. So two videos, one the sound is re-edited on was on blanking, bright light therapy for ADHD. So there's two published studies using the same bright lights that are used for treating seasonal affective disorders, winter depression. And both studies found positive reduction in ADHD symptoms using these bright lights in the morning. And this was clearly not due or attributable to any improvement in depression in these individuals. This strengthens the notion, some researchers who attribute a primary issue with ADHD being desynchronization of internal circadian clocks and rhythms. And clearly, more work and more reproduction of those results is necessary, but it's certainly avoids many of the potential toxic effects of medications. The second video was a new video, and I titled it Unthinking Violence. It's based on a book that University of Chicago economist, behavioral economist Jens Ludwig, Ludwig just released this year called Unforgiving Places. And I call it Unthinking Violence for two reasons. So we need to unthink what we already think we know about gun violence in America, and that the big majority of gun violence is happening from unthinking reactions rather than well thought out, calculated responses. So Ludwig uses Daniel Kahneman's System 1 and System 2 thinking to refer to different types of decision making, where System 1 is rapid, automatic, reflexive, and System 2 is thought out, slower, and reflective, and presents a wealth of data that indicate that most murders in America, and most murders are gun murders, happen from people misjudging situations, misinterpreting comments, getting emotional and responding quickly without thinking. And if guns are readily available, that leads to people being dead. And this insight suggests a different set of approaches than have been commonly applied or used to try to reduce gun violence in America. So I can happy to talk about more of those at length or shortly. I do see some questions have come in. So James Alexander questions, or how do we know that in nature, whether you're a salmon or a bald eagle or grizzly bear or human, there's about a 2-to-1 content in your body of EPA to DHA? Are there any peer-reviewed papers, medical textbooks, or other scientific sources that support this? If you look at studies of EPA DHA ratios in fish, they show ratios differing a lot from species to species. They lean more towards DHA. If you calculate out the averages. So some of this may be dated research, but I have books on this going back 20 plus years, and what I've found at the time, and maybe more and more information is needed to revise that. But what I found, and I'm pretty sure some of those were peer-reviewed studies, but maybe I need to go back and check that. So again, DHA and EPA are both omega-3 fatty acids. EPA is eicosapentaenoic acid, and DHA is docosahexaenoic acid. And those are just fancy Greek-derived terms for where the double bond in these molecules is, which affects how they move around and how many carbons in the molecule there are. So the omega-3 versus 6 is designating the position of the double bond. Um, and at least to my knowledge now, I'll go back and double check. Um, in most species, there seems to be some consistency with about twice as much EPA as DHA. Um, so I will. So and I also responded in the time that got cut off. So Doc Wana had, I think, in the talk last week, mentioned their experience with having hypoglycemic episodes while they were on lithium, and that some problems with hypoglycemia persisted after they stopped. I was not aware of any connection between lithium and hypoglycemia, and Doc Wana provided a good link to a 1986 study that documented, I think, 9 out of 12 people on lithium and 0 out of 12 in the control group showed problems with hypoglycemia while they were on the lithium. And looking at other research, there's not a lot out there, and there are some studies that seem to indicate lithium was protective against hypoglycemia. But again, at least one that documented this could be a side effect and might even persist after you stop. Um, so Tom Hardy mentions vortioxetine. I'm not knowing what context that's being offered in. So, so C asks, how does ADHD show up in men with extreme childhood trauma? I mean, one is ADHD can show up in a variety of ways in a variety of people. I guess is the question, I mean, one is, could extreme trauma mimic ADHD? Absolutely. Could you have both together? Absolutely. And we know that having ADHD makes you more likely to be experiencing trauma as a child, both accidents and other things. Some of them probably stemming from your own behaviors and actions, and some of it stemming from a child with ADHD is more likely to have parents with ADHD and more likely to have trauma in the household because of less structure and prevention of preventable traumas. Um, I could, I don't know. So can ADHD look like sociopathy? I'd say if you have sociopathy, I mean, if hello, sorry again for the problems. I'm completely dependent on Elon Musk's Starlink for any internet connection here. It had been good for most last week and good earlier today, and usually FaceTime is more susceptible than this seems to be. So I was in the middle of so answering this. I mean, the question is, can ADHD or complex PTSD look like sociopathy? And I'd say if you have the added features that you're behaving cruelly to others and not responding much emotionally to that kind of action yourself, then I would say that necessitates another diagnosis beyond just ADHD or PTSD. You can certainly have the two together, and there is some evidence that ADHD predisposes people to some personality disorders. I'll back off from sociopathy to say narcissism. I do have a video on narcissism and ADHD. Um, Narcissism or ADHD can often look or appear like narcissism, but there are certainly some individuals who have where it is clearly ADHD and it is not narcissism. They are not intentionally oblivious to the needs and cares of others. They're not inflating their own value or worth. It's just that they are so distractible that they don't remember to check in, to pay attention, to follow normal social conventions and niceties. Jack says that alcoholism plus ADHD can look like sociopathy. Um, yeah, I'd say alcoholism itself without other conditions can often show up as sociopathy. I mean, by definition, um, part of alcoholism or other substance abuse issues is that you are valuing your interaction with that drug or substance above your human connections, above your job, above your um, social life. So Larry is looking for some structured guidelines on ADHD coaching and developing healthy habits. There's so much information, but I'm looking for a more structured taxonomy of coaching techniques. Um, so I don't know what to say. I mean, if you're looking for coaching help, I mean, my approach would be to ask what problem, I mean, to identify with the coach what problems you are having or challenges in your life, and to ask them their experience and what approaches they are using to treat similar problems in others or help. I guess with the coach, they're not technically treating, they're assisting or working with. Um, so there are, I mean, when there are coaching organizations that credential people for ADHD coaching, so that's a low bar, but at least it's something to make sure that they have some standardized um, skill set and someone's evaluated them as having some competency at what they're doing. I'm not sure what more specifically I can say there. Max asks if I had a patient with ADHD who had a positive response to aripiprazole but had to stop due to side effects, which medications would you look to try next? So aripiprazole is one of the commonly called second generation antipsychotics or um, agents that move beyond just dopamine 2 receptor blockade. So the difficulty is in this group of, and now there's at least 15 to 20 different um, agents, unlike the older antipsychotics, all of which had strong dopamine 2 blocking action, and many of them didn't do much more than that. The second generation family, almost all of them are having two, three, four, five different clear, robust effects on different components of dopamine, serotonin, norepinephrine, and other glutamate systems in the body. And no two agents in this class are having the same pattern of effects. So there's much less um, similarity between them, at least at the simplistic mechanistic level. I mean, the drug that's clearly the closest overlap with aripiprazole is Rexulti. I'm blanking on Rexult. It's made by the same Japanese company, and I'm forgetting the company name. And Rexulti's um, other name. And yet, there's clearly many people who have different effects from in response to Rexulti than they do in response to Abilify aripiprazole. So, so, so my message there is that having a positive response, but having to stop the side effects may not lead us to a clear choice among the next options. James Alexander asks, is it, I'm trying to make a note of the DPA, DEA, DHA, so I'll look that up. James Alexander asks, is it true that amphetamines are the most pharmacologic intervention in psychiatry in terms of effect sizes and success rate? How do the effect sizes and success rates of methylphenidate and second-line therapies like straterin and Tuniv compare to those of other pharmacologic interventions like antidepressants for depression and anti-anxiety agents for anxiety? A good question and a pertinent question. It's just we sometimes wind up trying to compare apples and oranges. So I'd say if we're treating different conditions, I'm not sure. I mean, the effect size pretends to be an objective statistical measure of how powerfully beneficial something is, but particularly in psychiatry, that's so wrapped up in, I mean, the basic problem in psychiatry research, I still maintain, and despite decades of people far brighter than I spending their whole lives on devising measures to measure the severity or intensity of psychiatric symptoms at a given time to see if a intervention is having an effect, we still have a really lousy set of measurements. And I mean, one interesting study, and I'm forgetting which video I've mentioned it in, something about depression, is that one research group just added to, I'm not sure if they were using the Hamilton scale or one of the other very well established symptomatic lists of measuring the severity of depression, but they just added a single overarching, how much better or worse do you feel? And that measurably seemed to increase the um, meaningfulness of the severity scale in terms of, and made it much clearer what interventions were having an effect or not. So, given that effect sizes are so dependent on the number of individuals studied, the measure that's being used, the dosages being used. So one of the tricks of pharmacologic studies, if you're trying to compare yourself to a rival drug, is to limit that rival drug to doses that are less effective or more rigidly controlled. So there's also, so I I guess what I'm saying is I'm not sure that there's, other than sort of in very broad sweeping generalizations. So the broad sweeping generalizations is yes, within psychiatry and actually within medicine in general, the effects of amphetamines on ADHD are among the most impressive and largest effect sizes. And I would put the effects of non stimulants on ADHD and the effects of antidepressants on depression in a similar ballpark. Um, the other point I didn't mention is that placebo effects, certainly the size of the placebo effect alters how large an effect size you get or aren't getting or comparison. And it's not completely clear all the reasons why placebo effects have continued to increase over the decades. And this was first noted and observed in depression and anxiety in 30, 25 years ago. The claim was the placebo effect's pretty small in ADHD, and now over the last decade or more, the placebo effect in ADHD studies has grown fairly considerably. Whether that reflects that we have a larger, um, that the shift has gone from examining individuals with more severe ADHD to individuals with more moderate or mild symptoms, that might be part of it. It might be environmental or world factors making comorbid conditions actually more common or present, even if they're there at subsyndromal levels. Um, so that's where I would say there. So Jack asks, so I might have missed question. So hello, Dennis, again. So Dennis asked, to what extent is psychopathology relevant for understanding or preventing terrorism? That's a really loaded question. I mean, particularly, how are we defining terrorism? Right now in the US, the government has explicitly, the leaders of our country, many cabinet members. I'm being cut off again. Maybe Elon's at work here. Hello? Am I back? So part of it is how are we defining terrorism? Um, I mean, were the Americans, well, proto-Americans in 1773, 4 or 5 terrorists? The British would have determined that they were, who were fighting for or fomenting independence from America. Um, so I'd say, I guess I'm not prepared to go much further into whether it's a sign of health or whether it's a sign of psychopathology to stand up against tyrants or corrupt or evil governments. Most people who are engaged in terrorist labels or causes that others label terrorist believe at some level that what they're doing is true and right and just. Are certainly terrorist groups, some of them based on delusions, in terms of if we define delusions as tightly held beliefs in the face of that are false in the face of massive evidence to the contrary. That's certainly true, and a cult-like pattern is usually present among those type of terrorists. I'll stop there, I think. So thanks, Max, for providing the link between the narcissism and ADHD video. So Jack asks, could a nonverbal autistic child take ADHD medication? So two things I'd say there is that when we're saying nonverbal, and this is a one oversimplification or way to simplify. I mean, nonverbal can mean that someone is not able to use language effectively to convey what they're thinking or wanting, but it doesn't necessarily also convey that they can't understand or comprehend. So many children with ADHD who are not don't have expressive language clearly can follow a fairly broad range of, well, of simple commands, and this is not meant to be insulting, but a good comparison is your pet dog. Your pet dog is nonverbal. They're not able to express. They might even snore like Cupcake's doing now. They're not expressing their feelings, thoughts, or intentions with words, but they can understand a fairly broad range of sit, stand, food, walk commands. So many nonverbal, non-expressively verbal autistic children um, can understand that the directions to take a medication. The area that's been most studied is when someone has both autistic and ADHD symptoms. And in that setting, there are studies that show that traditional ADHD medications do have benefits for those ADHD symptoms. And most of the studies show very limited to no benefit for the remaining autistic symptoms that individual might have. So, Blue Bassett, can I explain a bit about the significance of this? UC Berkeley scientists mapped brain circuits controlling growth hormone release during sleep, revealing a feedback loop where sleep drives hormone release and the hormone influences wakefulness, making poor sleep, obesity, diabetes, and cognitive decline, opening pathways for new treatments. So I'm not familiar with the details of this study itself. So I guess I'm limited in commenting more. So I will try to look it up. Um, I mean, clearly, growth hormone we've known for decades has an extremely prominent circadian pattern to release of release. So it's big surge. My recollection is early morning. I'm not remembering before wakefulness or after wakefulness. Um, yeah, I mean, there's a number of systems that have feedback loops. I mean, so of course, yeah, I'll just stop there. Um, So thanks, Max, for the link on antipsychotics for ADHD, and thanks, Max, that it is Rexulti is brexapiprazole, and it's jumping around again. Um, Otsuka Pharmaceuticals is the one who developed it, and I think is, at least in the US, marketing it. James Alexander asks if Intuitive, Strattera, Cymbalta, and similar medications rewire your brain by promoting the formation of new neurons, which or type of brain cell do patients experience a minor form of brain damage when they go off these medications and those neurons die off? So, a couple different things. One is particularly with guanfacine, and um, rewiring can imply two different things. So, it can imply changes in the connections, the synaptic connections between cells, or there is some evidence in the depression field with SSRIs and SNRIs actually promoting new nerve cell growth, particularly in the hippocampus. So, rewiring again can be the addition of new cells, or it can just be adding synapses, making connections, more connections or stronger connections in areas that there were already some connections. Secondly, the thought or hope is that part of what might sustain new connections or the health of even new nerve cells is that the medication may encourage or allow new patterns of behavior or new patterns of thought. And if the person practices those patterns or thoughts over time, they may be continued to some extent, even in the absence of the medication when that's taken away. So, in that scenario, you would say that what's ever still continuing to strengthen the synaptic connections is continuing, and we wouldn't expect some deterioration or dieback. Um, Yeah, so I'm not aware of any study that's indicated or found damage or dieback after medications have stopped. And this is a stretch or far off, but I've just been reading in the American Journal of Psychiatry's latest edition several articles about ketamine. And although the ketamine proponents sort of shrug it off, there's, I'd say, some considerable and growing evidence that some percentage of people with ketamine who use it effectively for depression, when they stop using it, enter profound depressive, suicidal states, and that may represent some withdrawal and or neural change for the worse pattern. I mean, it's clearly not universal, and it's clearly small enough sample to make it confusing how to sort it out from the background rate. Um, but at least some studies suggest it's a real potential problem or phenomena. So Wino said something I have a really hard time wrapping my head around is that while ADHD medications improve academic performance in regards to quantity of task completion, it doesn't seem to improve academic achievement or learning. What are your thoughts on that, and why would that be? So, the commonest explanation is that intelligence is separate from executive functions. So, intelligence is your store of, there are multiple measures of intelligence, but one, particularly in a classroom academic setting, would be your store of information and how well you can apply it to or contextualize it to appropriate questions or situations. Whereas most of the focus on ADHD is not that it's an intellectual problem, but that it is a executive function problem. So your impulsivity, your attention, your ability to stay on track, your ability to scan for mistakes is um, impaired, not your intelligence. And that in an ideal world, maybe that um, So again, that these drugs that help you perform better on executive functions aren't boosting your intelligence, so we wouldn't expect them to boost your grade performance or scholastic performance on academic tests. That's the commonest explanation. So Lucky Lady 38 asks, can bright light therapy work for ADHD? Yes, I've discussed it. I'll summarize it again because I don't know how many times I've been cut off, and I'll keep it short. There's at least two, so one, I do have a new reworked sound video on this, but there's at least two different studies done several years apart using the same bright lights used for seasonal depression, showing measurable decrease in ADHD symptoms, and the correlation between improvement was with how much internal clock measures of circadian clock shifted, and it was clearly not just due to any improvement in depressive symptoms in these individuals who weren't particularly depressed. And this reinforces the notion that for some people, or maybe many people with ADHD, a central issue or problem at a neurofunctional level may be desynchronization of different circadian clocks, and that the bright light may be synchronizing them so your brain is working together more effectively. So James Alexander asks if any of my patients were unable to tolerate modafinil or armodafinil, um, what made them intolerable. So generally, I'd say particularly compared to stimulants, modafinil is more tolerable. So the commonest reasons I've had people not continue taking it was they couldn't discern any effect. So that should be said, number one. But in terms of intolerable side effects, I've certainly seen people who had headaches, and I'm trying to think of any. Very occasionally people have nausea. That's not usually a reason to severe enough to stop it. Um, I haven't had anyone who had significant heart rate, blood pressure issues, which again fits with most of the research on it. So I'd say headaches have been, I think, the only reason that's coming to mind. I've had people stop um, modafinil or armodafinil, other than that they didn't see an effect. So Blue Bassett asks, do I often have patients for whom the cardiovascular side effects of Adderall outweigh the benefits? And I'd say, and then they list that their heart rate is significantly elevated when sitting down and maybe at nighttime as well. And is this cause for concern? Um, and it also seems to give them insomnia, whereas methylphenidate doesn't work well. So I'll tackle the insomnia a little bit piece first. I mean, particularly using an immediate release rather than an extended release may help. What I've seen over the years in a number of people is that sometimes just taking the medication an hour earlier has more than an hour's worth of benefit at the end of the day. I don't have a good explanation for it. Um, and I've had many people who actually set an alarm, took Adderall or another agent an hour before their wake up time, took it, went back to sleep for an hour or two, and then they woke up. The drug is working well for them, and again, seem to have less carryover at the end of the day. I should have prefaced at the beginning of this talk, none of the things I'm saying are specific recommendations for your case. They're for informational purposes only. So the other thing in terms of cardiovascular effects, I've certainly seen people who are already on antihypertensive agents and who needed to increase the dose of the antihypertensive agents while they were on it, while they were on a stimulant. And most of these individuals have felt that the significant benefit they got for their ADHD symptoms outweighed any potential incremental effect for their blood pressure or cardiovascular parameters. The other really hard issue to disentangle is that anxiety, sympathetic overdrive are, I mean, is a response to having something new, different, alien in your body. If you're already worried, is this going to affect my blood pressure? And then you're worried about it, you are almost certainly guaranteed to perpetuate or exacerbate increases in blood pressure or heart rate. So I almost always include some amount of cognitive behavioral training in that situation to, and I do have a video on panic and CBT, I think. I'm not sure what it's called, but essentially telling your brain, yes, this is having an effect on my body. Yes, my body is responding a little differently. And no, this is not cause for alarm. This is not danger. This is not, hopefully, the component due to anxiety and sympathetic revving separate from what's directly caused by the pharmacologic agent can be tamped down or ameliorated with time using CBT approaches. Um, so, Dennis is getting back to the question about psychopathology and narcoterrorism. I mean, one aspect that certainly needs to be considered is, and I don't know of any controlled studies or that it would be particularly easy, but a common observation is many people involved in the drug industry are using their own product. And again, to the extent there's some addictive component, that changes how we balance rewards and how we think and weigh the consequence of our actions. So, and there's a lot of overlap between sociopathy and, and narcissism and addiction in that regard. I think, at least from what I've seen, and again, this is not systematically studied, there's many people who justify their involvement in narcoterrorism as they're just providing things that other people want. They're not creating the want. So there are ways of making some themselves or encouraging their not looking at the actual consequences of their actions. Yeah, that again, I don't know how much this has been studied, and even it has been studied, I would question how representative the samples are, how candid the answers are, and I mean, I think the best answers would be from sociologists and others who have studied sort of more in depth how people get involved in narcoterrorism and how they behave in such systems. And I'll stop there. Lucky Lady suggests people need to ask their personal doctors these questions. Again, I'm happy to entertain questions at any level, but and because I think I do have useful information. But again, these are not specific recommendations. Take it back. And many times, people's individual doctors aren't aware of some of the things we discuss here, and this can be used to educate them. So, James Alexander asks, is it necessary or beneficial at all to supplement trace minerals like manganese and molybdenum using sea salt or trace mineral capsules, drops, tablets? Have any of your patients benefited from supplementing them other than zinc? Um, so, one is that there's what is considered a trace mineral versus some people would say that copper, zinc, magnesium, iron that we need in tiny amounts, but greater than trace amounts aren't trace amounts. I mean, when compared to the body weight overall, these are all small, tiny amounts. So I've certainly seen magnesium be helpful in people with ADHD. Um, One of the difficulties is that of the few studies there are, many of the interventions involve supplements that have a multitude of trace substances. So even if they show an effect, it's not clear whether it's just one component of this mix, whether it's all the components of the mix, whether it's an interaction between a few of the different components. Um, I'd say most people in in modern societies are eating a varied enough diet that, and again, I'm not saying that dietary deficiencies or problems aren't a major social issue and health issue. They are, but I'd say it's seldom, the evidence so far has not suggested that most people are completely deficient in trace minerals and substances. That's a sweeping generalization. So I'll leave it there. Jack comments that they once saw a guy from Bolivia who told me he worked in the coca fields and used to chew a lot of coca leaves and then drink a lot of coffee with chocolate and sugar. Do any of these foods have properties for ADHD? So, although there aren't a lot of studies in the last 20 or 30 years, there's studies going back 30, 40 years ago that caffeine, coffee are both beneficial, are measurably beneficial for reducing ADHD symptoms. I don't know off the top of my head if there are any formal research studies looking at the effects of cocaine. One would expect by analogy from what it's doing in the brain that it would have effects roughly similar to other stimulants. In the US, it would be very hard to get approval to use cocaine for research on ADHD. I mean, cocaine actually is not a category one, so it's not as, or schedule one, so it's not as dangerous as marijuana, according to the official, or psilocybin or peyote, which I believe are all schedule one. So cocaine is used as an anesthetic in some eye and ear, nose, and throat surgeries. So it constricts blood vessels as well as producing some analgesia. Um, but I don't know of any studies on it formally looking at ADHD. So I do have some videos on, I mean, in general, eating foods is a poor and inefficient way to boost or change neurotransmitters. That doesn't mean they can't ever, but there's a host of reasons why most of what you eat just gets broken down into simple components and that it's hard to affect neurotransmitters activity. Not impossible, but that's where I'll leave that unless there's a more specific. So James Alexander, and I'm going to try to race through what's left in the few minutes, says in the last Q&A, it was mentioned that certainly family constellations growing up leading people to be quiet, just sit passively listening to group situations, despite being able to converse at length in one-on-one. What are family constellations? So this is personal. Um, you're asking about my own life, so I'll just share and frame it as both mother and brother were very opinionated and strong in enforcing their opinions. And in retrospect, my analysis is it didn't really matter what I said. It would be criticized and or ignored. So I think at some level I learned there wasn't much value in speaking up in those situations. I think that's not an accurate lesson to have learned. Um, there. So Max, thanks for providing the link to stimulants and cardiovascular risk and the video on panic attacks and CBT. So again, I think that one's particularly useful for a much broader range of activation of the sympathetic nervous system beyond just full-blown panic attacks. Hi, Borislav again. Good morning. Thanks. And Nick Lewis, you're welcome. Wino asks for academic performance. I'm familiar with the not improving intelligence explanation, but does that mean that studying / homework doesn't help for academic and tests of our stimulants just not helping and or motivating students to study? Yeah, What I'll say is I don't think we actually, despite people doing good research in academics and learning, I'm not sure that our academic system necessarily measures or rewards people most for what we should be rewarding. And I'm saying that as someone who excelled by many of our traditional measures and got close to perfect grades and really good test scores. But I'm not saying they're measuring nothing, but I'm not sure what they're measuring in them. So that's separate from whether the drugs help in terms of performance in ways that are just being captured by, I mean, in a similar vein, we have some very well detailed ways of measuring executive functions. And we think of ADHD as a problem of executive functions, but a variety of studies have not found massive shifts in executive functions on people taking medications. Partly, again, some of it is the testing situation is minimizing the baseline impairment in executive functioning you're probably seeing in the real world in people with ADHD. Um, so Nick shares that they have a treatment plan for their OCD ADHD sensory motor dysregulation, which includes duloxetine, lamotrigine, mirtazapine, and magnesium. And it's been working great so far. So thanks for sharing. And I'd say each of those components certainly seems to have some valid reason for being there. Um, whether there's some overlap directly or indirectly between duloxetine and mirtazapine, they certainly do have some effects that are specific to one and not both. Um, you're welcome, Lionel, for the bright light therapy video. He's taking early morning walks recently and found it too difficult to sit still for the 30 minutes in front of the bright light lamps. So one thing, I mean, I would natural sunlight and being out of doors and walking all have advantage in addition to their light component. So I would certainly encourage that approach first. Um, Many people with the bright full spectrum white lights find them too glaring and uncomfortable to look at. And there's good evidence that bright blue lights, that it's the blue end of the spectrum that activates the circadian clocks or helps reset the clocks. So that may be more tolerable. And at least in the old days, because when I did research in this in the mid 80s, this is the day of newspapers instead of computers. Again, you don't need to be staring relentlessly at the bright light. You do need to have it close enough because the intensity of light falls off with the square of the distance from it. So if you're 3 times as far away from the light, you're only getting a ninth of the photons hitting your retina. Um, and it is retinal exposure that seems primarily important. But as long as it's getting into your eye, it can be sort of your roughly peripheral vision. So you could put the light source next to your laptop or computer if you're using a computer, or again, reading the newspaper or reading a book. You don't need to, it doesn't need to be hitting the center of your retina. It just needs enough of it needs to be getting in. So Nick asked about Sunosi, and I do have a video on Sunosi. They're working their way through getting it approved for ADHD. I'm a big fan of Wellbutrin for ADHD, and largely the mechanism of action, dopamine and norepinephrine reuptake action, suggests that it will be useful there. I have not used it very extensively at all, just because it's pricey and hard to get permission for as an off-label use when there's particularly other options for ADHD. Um, James Alexander asks if there's any new updates on magnesium since my video on it of a few years back. So I'm not aware of any new developments. That doesn't mean they're not there. Thanks for showing up and asking good questions. And so I'm going to save Blue Bess. I'm going to save questions because that's a really good one. So I'm going to sign off and hopefully the question will still be there. So thanks for being here. Thanks for having good questions. Thanks for good interactions between each other as well as just listening to me. And sorry for the bad connection. And I will try to get to Blue Bassett's connection about having ADHD and whether that reduces cognitive decline in later years or not. That's all.